For talk number 9, we're going to do percutaneous LVADs, and the basics of these is that they all augment LV function only. They're all inserted into the cath lab, and then they all require anticoagulation. We'll do intra-aortic balloon pumps first. So balloon pumps are access to the femoral, subclavian, or axillary artery. They add between 0.5 and 1.5 liters per minute of cardiac output. And how these things work is this balloon is closed during systole so that antegrade blood flow can occur in there, and it inflates during diastole. And what this does is it augments the diastolic blood pressure, which improves coronary perfusion, and it also decreases afterload by displacing thoracic aortic blood. And settings-wise, you can either have it open with every heartbeat or close and open with every heartbeat, which is 1 to 1. Every other is 1 to 2, and every third is 1 to 3. You're going to get more support, obviously, with 1 to 1. And when you're weaning this and going down to 1 to 2 and 1 to 3, you just have to be mindful of the increased thrombosis risk. So when you wean and take it out, it has to be done within hours to prevent thrombus from building up on the balloon. And it might be obvious from the mechanism, but the indications for balloon pumps are primarily ischemic heart disease. And this is because it will augment flow and help the best in ischemic patients due to its mechanism of action. And it can be used in STEMIs as a bridge to recovery. What we usually see in the CTICU is a patient with triple vessel disease who has an NSTEMI, and a balloon pump is used as a bridge to a bypass surgery. And these are also sometimes used to help wean patients from bypass in the operating room. And some contraindications: severe AI, because it will cause a balloon to migrate; aortic dissection, because you don't want a balloon pressing on a fragile dissection flap; and severe aortoiliac occlusive disease, because it can cause femoral artery occlusion at the insertion site, and it can also knock off plaque when the balloon inflates and deflates. And some complications of balloon pumps: the first one and the most common one is migration. So we want this a balloon placed just distal to the left subclavian artery and above the renal arteries. And when it migrates proximally, it can cut off blood flow to the left arm, and if it migrates distally, it can cut off blood to the kidneys. So you can see them on chest X-ray. You also sometimes have to pay close attention to that arterial sheath to see what number that it's at centimeter wise. It's usually between 70 and 90. The next complication is leg ischemia. We already talked about that. If the patient has arterial insufficiency on that side, you need to either change the location of a balloon pump or take it out. And then a balloon rupture is a very rare complication. I think I've seen it twice in 3 years. But when the balloon does rupture, it needs to be replaced immediately, and then so the patient should be then rushed to a cath lab, and old balloon pulled out, and then a new balloon placed through the same sheath. Okay, we'll go to Impella next. So I had to, let me make this a little bit better. There we go. We'll now you can't see the tandem heart next. So what an Impella is it's also, we'll talk about the access first, and it's access via femoral subclavian or axillary artery. It adds 1 to 5 liters per minute of cardiac output, and it has a kind of a interesting mechanism of action. It's a hollow tube that has a magnetically levitated impeller, and it's all that is. It's like a screw. So it's like a inclined plane wrapped around like a rod, right? So it's a screw. It's rotated at high speeds, and it accelerates blood from the left ventricle past the aortic valve into the ascending aorta. And settings, settings go from P1 to P9, P9 being the higher setting. Depending on the devices, it can stop at P8 or P10. That's neither here nor there. Just know that the higher the P level, the more flow that you're going to get. Due to its unique design, it does require a purge solution, and what that is it's usually a heparin in a D5 that is slowly pumped through the device in order to keep blood and other debris out. And sometimes sodium bicarb is used, but the best purge solution is heparin in D5. Indications, though, primarily LV failure as a bridge to recovery VAD or a heart transplant, especially in ischemic patients who have only LV disease. These things, impellers will not help for RV failure. You need ECMO or something else. Another thing that it's used for, and I hinted at this one in the VA ECMO lecture, was LV decompression while the patient is on VA ECMO. And I'm not going to go into too much detail here with this. That's a whole other talk. But just know that if you want to decompress the LV when a patient is on VA ECMO, Impella is an option. And the other setting that we see this is high risk CABG or a PCI. The contraindications, not very many. I think Impellas are generally safe and well tolerated, have a favorable complication profile. The main contraindication of this are severe AI. This is going to prevent a uniform flow through the device and a small LV cavity. And this is because if the cavity is too small, the device cannot suction enough blood in order to increase cardiac output in a meaningful way. Complications, there's kind of three big ones, and these are all, I think, fairly common, but they're very fixable. The first is device migration. So you can see that the device sits past the aortic valve inside of the left ventricle, and it needs to be about 3 to 5 centimeters inside of the LV. So if the device starts to migrate out, you're going to have flow alarms, issues. I had a patient once who had like these weird right arm paresthesias when the device started to migrate out. So if anything is fishy, always use POCUS. Look at the device, make sure it's in the right place. And if it's too far outside of the valve, it has to be, you have to go back to a cath lab to fix it. Malposition is different from a migration because malposition refers to the position of the impeller or of the impella while it's inside of the LV. So I drew a little tail on it. Some of the models have tails, some don't. I'm not going to go into that. That's a talk for another time. But the impella should be pointing towards the apex of the left ventricle. When it's pointing towards the mitral valve, it can cause problems. And again, POCUS can diagnose this. And the third complication, probably the most common one, is suction events. And what suction events are is the LV collapsing over the inflow outlet of the impella, and this is usually due to either a migration, a malposition, or more commonly just the patient's volume down. So giving them a little bolus of albumin or fluid generally solves the problem. And then using, again, ultrasound to confirm the position of the impella. And we'll move on next to balloon pumps, or to tandem hearts. We'll get this sorted out, okay? So tandem heart is not truly a percutaneous VAD. I included it because there was no other place to put it. And accesses ephemeral vessels only. It's going to add between 1 and 1.5 liters of cardiac output. And the only setting that you really need to worry about are the RPMs, because it doesn't require an oxygenator. An oxygenator is sometimes put on, and we'll talk about why later. The how this works is we'll go over the inflow and outflow cannulas next. So the inflow cannula is inserted into the femoral vein and then crosses the intraatrial septum to drain the left ventricle or the left atrium. And that oxygenated left atrial blood is then goes through the ECMO machine and then is accelerated and it drains into the abdominal aorta through the outflow cannula. So these cannulas are I drew them both in red because it should be all oxygenated blood. And the main indication for this is LV failure as a bridge to recovery, VAD, transplant, or you can also do it if a patient has a LV problem that has a surgical solution. A device has very few contraindications. It's just not used as much as it could be because other devices are just more convenient. The main complication of tandem hearts is that inflow cannula migrating into the right atrium. When it does, it creates a massive right to left shunt. So sometimes a cardiologist will put an oxygenator on the circuit. That's why I drew that plus or minus sign, because if it does migrate in the middle of the night, it does not result in an emergency. Then it's functionally VA ECMO, and then a cardiologist can come in the morning and fix it under an urgent basis rather than running in the middle of the night as an emergency. And so let's take a minute to compare tandem hearts to VA ECMO. The tandems are slower to place. They're more difficult to place because you have to do the transseptal puncture and it has to happen in cath lab. It also only treats LV failure. So it's limited in placement and scope, but it has fewer complications than VA ECMO. And part of that is that this is tend to be done on healthier, more stable patients. So there is a selection bias there as well. The VA ECMO is faster to place, easier to place, and it can treat multiple pathologies. So if someone crashes, if all else fails, you can always put them on VA ECMO at the bedside. That being said, VA ECMO does have more complications. This is, but again, like patient selection and a selection bias is key. Tandem hearts tend to be done in healthier patients on a more elective basis, so there's going to be fewer complications, whereas VA ECMO, emergency, sicker patients, you're just going to have more complications. So the complication rate is hard to tell if one device inherently causes more or not. It's probably due to the situations under which the device is used. Tandems are generally preferred for established LV failure refractory to medical therapy, and VA ECMO is preferred for undifferentiated cardiovascular collapse. So I think that's like the big difference between the two. The last patient that I saw a tandem in was a guy who had a previous mitral valve replacement, and he had shortness of breath for a month. The valve thrombosed, and his LV was starting to fail. And so he otherwise a healthy guy. So we put him on a tandem heart for about 36 hours to decompress the LV, and then you got to redo MVR the next day. So that's like a perfect tandem candidate. So again, this guy was semi-elective, healthy guy besides this valve issue. So we didn't need to put him on VA ECMO. So you're going to get these niche situations where it is useful, but these are overall tandems are going to be pretty rare. You're going to see balloon pumps, ECMO, and Impellas more often.